Hello, and thank you. I want to specifically thank Joe Grima and Kim Eagle for the opportunity to speak at this year's GenTAC Aortic Summit meeting. Kim actually came up with this the title of this talk, so I credit him with this, and I assume his desire was to hear my thoughts on how to handle these, particularly these aortic roots. So without further ado, I know this group is well versed with the genetic triggers and how they impact the thoracic aorta in particular. So I don't want to belabor this point other than to say that these patients can develop marked aneurysmal disease and in fact cause dramatic derangements in the extracellular matrix inherent to the aortic wall that gives rise to these impressive aneurysms. And the different genetic triggers can incite different forms of disease within the extracellular matrix. And these can give rise, these are examples of the Marfan syndrome specifically, of marked derangements in both musculoskeletal structure and function, but more distinctly to the thoracic aorta, giving rise to these, in some cases, really massive aneurysms that are quite lethal if untreated. The other issue that's inherent to these genetically triggered thoracic aortic aneurysms is the fragility and friability of the tissues, the aortic tissues in particular. Here are two examples, one on the right showing a tear in the aortic root, indicative of an acute dissection, and the other just showing a markedly effaced sinus segment in a Marfan root with an incredibly thin aortic wall as depicted here. The bicuspid valve, also a genetically triggered quote-unquote syndrome. I'm always struck by the fact that we generally don't use the term syndrome for bicuspid disease, when in fact it probably does represent a syndrome, given the fact that valvular disease is associated, ascending aortopathy is associated, and coarctation is all associated with bicuspid, justifying the term syndrome. So factors to consider when planning aortic operations are all listed here. Age and life expectancy. The predominant age category for these patients with genetically triggered aortic disease is such that they are generally young patients, young adults, in some cases children, and consequently all have a reasonably long life expectancy. And other things to consider: the presence of dissection, the location of an intimal tear, the degree of vascular or aortic calcifications associated, the overall quality of the tissues, how friable, how fragile they are, the demonstration of concomitant valve disease, and of course, surgeon outcomes. There are many options that we now have for treating aortic root and proximal thoracic aortic disease, many of which are listed here. But when it comes down to the genetically triggered aortopathy population, it really, the conversation about what valve replacement technique to use generally settles on this, notably deciding between a mechanical composite versus a valve-sparing approach. We have amassed data across the world demonstrating success with both of these strategies. This is the Hopkins experience with Marfan patients treated over the course of almost 30 years. And what they note, two distinct findings. One is the long-term survival, even in the context of dissection, is actually quite good, in some cases better than older populations that undergo aortic dissection. But that said, they also, the majority of these patients were treated with mechanical composite, over 200. About 85 patients were treated with a valve-sparing approach. And they showed that both techniques work very well. We have to credit Tyrone David also with demonstrating the safety and efficacy of a valve-sparing approach. And the Mayo group has demonstrated some years ago an equivalency between a valve-sparing approach and a replacement strategy, valve replacement strategy. This was the multi-center Marfan study done to try to come to terms with whether a valve-sparing approach or a mechanical composite approach for root replacement in the context of the Marfan syndrome, whether one was better than the other. And the results were, these are the first year and a half or so results, and demonstrate that in reality, similar to the previously shown data, the two generate a nearly equivalent survival curve and very similar freedom from valve related morbidity. That said, one striking fact that came out of that multi-center trial was that roughly 7% had greater than or equal to 2+ aortic regurgitation at 1 year. And that fact alone is motivation for the approach that I've taken in handling these patients. So there's been many variations of the reimplantation technique. Most have abandoned the remodeling technique, so I won't spend any time talking about that, particularly in the context of the Marfan syndrome. Most groups have embraced the concept of reimplantation when opting for a valve-sparing approach. And there's a wide spectrum of techniques that are utilized. The first technique that David used, in fact, was one of using a cylindrical graft. And one concern that's been raised with the use of a cylindrical graft is the fact that with the loss of distinct sinus segments, there is concern about stress and strain on the aortic cusps, as depicted in this, which was time-lapse photography, which has been captured still here, and you can see this furling and curling of one of the cusps. This is at diastole, and then at peak opening, you can see this furling, and you don't get a nice effective circular orifice. So this is Axel Haverich's data from Germany, demonstrating that this cylindrical graft can also, similar to other techniques, generate very good long-term results with survival out beyond 10 years. It's quite good with low operative mortality, but again, a fairly large percentage of patients developing some degree of aortic insufficiency during their follow-up. And this distinct fact is what motivated me to take a slightly different approach. And I began earlier on, some near 20 years ago, looking into how we could study valve function in the context of a valve-sparing root operation. And I utilized time-resolved 3D MR using velocity flow mapping to try to determine what is the difference in flow across these pathologic roots relative to normal. And in the normal state, with normal size sinus segments, you get this is all, the white depicts laminar flow exiting out of the page, right through the aortic valve. And in the normal state, you see a nice circular effective orifice with nearly all laminar flow. In the Marfan patient, however, with large sinus segments, you see that the eddy currents that are created within the sinus segments force the cusps inward, even during peak systole, to create this triangular shaped effective orifice. The reason this happens is related to the construct of the root itself, and the fact that valve function is dependent on all four components of the aortic root: the annulus, the cusps, the sinus segments, and the sinotubular junction. And derangements of any one of these can impart valve failure and regurgitation. I credit Swanson and Clark from Washington University back in the early 70s to demonstrating that in the normal state, despite marked differences in body size, shape, weight, height, the dimensions of the aortic root and relative ratios of one dimension to another are preserved across humans. The knowledge of this fact can be leveraged in the context of valve-sparing root replacement to allow for a tailored approach to restore the geometry such that the ratios are returned or restored to normal. There's also been some debate about whether the focus during reconstruction should be on the surgical annulus, the so-called ventricular-aortic junction, or the true anatomic annulus, the hinge point where the cusps attach to the outflow tract and base of the aorta. The other distinctly notable fact is that even in the normal state, people's sinus segments are not symmetrical. They're in fact, each of the three sinuses demonstrate different size and shapes, even in the context of a normal valve, normal anatomy. And again, I think that knowledge can be leveraged to design an operation to try to mimic normal geometry. And that's been my goal in the approach toward these patients. Designing and tailoring a graft to accommodate and recreate normal dimensions, normal geometry. Creating distinct sinus segments that are tailored specifically to the cusp size and shape. And in doing so, this is a post-operative MRI following valve-sparing root replacement where you can see distinct sinus segments have been created, with the hope that this will result in a durable valve repair. All three of these patients, each with distinct valvular morphology, tricuspid, a type 0 or true bicuspid, and a type 1 or raphe bicuspid, tailoring sinus segments to accommodate the specific morphology. In this case, 3 distinct sinus segments, in this case 2, in this case a false with a larger sinus segment and a smaller posterior or non-coronary sinus segment. Each of these having undergone valve repair and reimplantation using this tailored approach. The other again, concept related to this, to the drive toward restoring normal geometry is to perform an annuloplasty. And with the utilization of the anatomic annulus as the fixation point for a graft, one can markedly alter the annular geometry. In other words, in the context of an effaced aortic annulus with marked annulo-aortic ectasia, the subcommissural triangle geometry can be restored by using this type of technique. The other is a respect for preserving the angle with which the aortic root and ascending aorta extends into the arch. In the normal state, this angle is roughly 120 to 130 degrees. And restoring this to normal and preventing any kinking of graft material will allow for more normal flow dynamic through the aortic root. So here's an example of studies done. These are phase contrast 3D MR. Try to get these to play. Yeah. Contrast the normal state, the preoperative Marfan patient, and the postoperative. You'll see that this pathologic triangular shaped effective orifice driven by these eddy currents created by these large sinus segments can be eradicated by restoring the sinus segments to more normal dimensions. And you see this is the same patient, and we've changed that effective orifice from one of a triangular shape to one of a circular, much more normal. Quantitatively, I demonstrated that when calculating the degree of laminar, turbulent, and vortical flow using this form of phase contrast MR, we can show, if we compare aneurysmal patients to healthy volunteers, you can see the relative percentage of vortical to laminar flow. And with valve-sparing root replacement using this tailored reimplantation technique, we can restore the degree of vortical flow to near normal with this approach. Many groups have demonstrated the safety of doing this type of operation in the context of genetically triggered patients. Again, most of these are otherwise young and physiologically healthy people. And we've shown very low mortality and operative stroke rates, very low incidence of pacemakers. In my experience, very low incidence of need for reoperation with this approach. I have taken one Marfan patient back for aortic regurgitation recurrence at 11 years post approach with this tailored reimplantation technique, and one bicuspid that done at 3.5 years for a reconstructed cusp that had been partially replaced with fresh native pericardium, developed a perforation at 3.5 years, went back for re-repair. So I've applied a similar strategy for the bicuspid population that I have for the Marfan population, in that an anatomic and reconstruction designed to create geometry for each respective cusp appropriate for the anatomy of that cusp. The technique for bicuspid is similar to that used for tri, and involves cusp repair, annuloplasty, as well as the creation of neosinuses that are tailored to accommodate the specific cusp anatomy, such that two distinct sinus segments are created to accommodate the cusp anatomy. This is a patient that has undergone this technique, and you can see we've created distinct sinus segments to accommodate these repaired cusps. This is an example of how this technique is used, even in the context of severe aortic regurgitation. This is a 26-year-old with type 1 bicuspid with the RN configuration, with an associated sub-aortic stenosis. This is his repair 2 years out, low gradient, no insufficiency. And these are examples of dynamic CT demonstrating, again, the geometrically based reconstruction of these roots, both of these having undergone the same technique. This is a patient 12 years out after the same technique with bicuspid repair, cusp reconstruction, and valve-sparing root replacement using this geometrically restoring reimplantation technique. You see, even at 12 years, the highly functional valve with no aortic insufficiency, same patient a year and a half later, still functioning, developing some calcification on this one, near this one side of the annulus, but also has now developed new MR. So this is an example of a patient who went back, here it is, dramatically and somewhat acutely evolving severe mitral regurgitation at 13.5 years post-op. And here we were able to go back in, we did nothing to the reconstructed root and repaired his valve. So in summary, I conclude that genetically triggered patients require a very nuanced approach. They demand respect for the fragility of the tissues, and this requires some distinct intraoperative patients. I have largely focused on restoring geometry back toward normal, and with that focus in mind throughout these reconstructions. Again, requiring some patience, but generating to date some favorable results. But to the point of the last patient presented, these patients require vigilant follow-up, not just for their potential for recurring more distal aortic disease, but also for other valvular disease, as noted in the patient with the bicuspid valve and subsequent evolution of severe mitral regurgitation. Again, I want to thank both Kim and Joe for the opportunity to speak, and I look forward to hearing everyone else's presentations.